Greetings and welcome to day 3 of the 12th Annual Symposium on Global Cancer Research. As everybody is starting to log in and get settled, allow me to reintroduce myself. My name is Mishka Kohli-Sira, and on behalf of our director, Dr. Satish Gopal, the team at the Center for Global Health at NCI, and the ASGCR Steering Committee, it's my pleasure to welcome you today. Before we kick off today's exciting events, I'd like to take a moment with a Zoom virtual round of applause to recognize the speakers and presenters and moderators from yesterday's sessions. And I hope all of you the attendees have had some fruitful interactions and with the poster presenters and with each other in Gather, as well as earlier today. If you did not join us today, no worries. You can catch up on what you missed because we do have all the sessions recorded. As per usual, I'm going to run through some of the logistics before we get started. As I just mentioned, our symposium is recorded and the recordings will be made available after we complete the symposium. We are keeping all the attendees on mute throughout the course of the symposium. But you can utilize the chat function to send your questions and comments. And if you're having any audio issues, you can post a note in the chat for us to help to try to address it. Please note we are also including simultaneous interpretation in Spanish and French and Portuguese throughout the course of the symposium. Please make sure that you select the globe at the bottom of your screen and select the language, either English or French or Spanish or Portuguese. And today's session, after the Meet the Abstract Author session, we will have presenters who are presenting both in Spanish and Portuguese. So a special note to English speakers, you also must select a language. Don't just use the main globe. Everybody must select either English or French or Spanish or Portuguese, and we'll try to make that reminder throughout. And we're very excited at that opportunity to be able to hear different presentations in different languages. So in addition to simultaneous interpretation, we also invite you to join us on social media, on X, and please, you can use the hashtag ASGCR24, and you can also tag us at NCI Global Health. So please join me now in welcoming our ASGCR Steering Committee member, Dr. Eduardo Kazap, who will give today's opening remarks. Dr. Kazap has been a member of the ASGCR Scientific Steering Committee for the past 2 years. He's the founding president of the Latin American and Caribbean Society of Medical Oncology, an editor-in-chief of eCancer Medical Science, amongst many other achievements. I've known Dr. Kazap in his capacity as a longstanding partner in the International Cancer Control Partnership. Again, you can read about Dr. Kazap and all the other speakers on the ASGCR website. So without further ado, Dr. Kazap, I'll turn it over to you to give today's opening remarks. Thank you.
Thank you very much, Sarah, and good morning, good evening, good afternoon, everyone. And welcome to this year 2024 symposium. It is, I think, crucially important to recognize the value of research in the development of cancer care and prevention. But let's analyze a minute the concept of global cancer control that is the topic of today. Cancer control means all actions that are directed to lower the incidence of cancer and improve curability and survival. But this is not limited to early detection and treatment. Cancer control means the full spectrum from education, information, research, primary prevention, secondary prevention, proper diagnosis and treatment, palliative care, end of life, morphine access, and survivorship. That is the concept of global control. All actions directed to improve cancer care and the well-being of healthy or sick people is part of the agenda of cancer control. And let's a minute analyze the word global. It is usually defined when you are analyzing the situation in different parts of the world, the issue of high income or low income countries. And I think that that is not the proper way to face the matter. All countries in the world, even the richest countries, are affected by gaps, limitations, and a myriad of obstacles to give to our populations the proper cancer care and control. Please, we need to recognize that the current knowledge about science and medical care and cancer applies to less of 10% of the world population. You have pockets of people that are lacking of the proper access and resources in very rich countries. Migrations, wars, and a list of social and economic troubles are making the cancer control actions very difficult from a global perspective. So something that is very important for the community of global cancer control is to have an open discussion about all these matters that are not only medical, can be also social, with of new ways of research that should be a priority for many countries and groups. One is implementation research, to make real the knowledge that we have and the proper actions. And the other is health systems research. The majority of the countries of our regions are facing a crisis about healthcare, and that was clearly demonstrated during the last pandemic period. And we still have health systems not prepared, not resilient to face next crisis in the healthcare arena. So we do hope that these days of the symposium will put some light about critical issues that are very well presented by speakers and different chairs during the sessions. So please, we will continue now with the program of the day. With the, you can see here, we will have now the rapid fire abstract session about global cancer control. The chair of the next session is Raman Gu. She's a fantastic global researcher from the Society of Preventive Oncology and has many medals in the field of global research. So I hope that you will enjoy the session. Rama, you have the floor. Thank you very much.
Thank you so much, Dr. Campos, Kazap, and for your great remarks. The purpose of this session is to provide opportunities for a diversity of researchers to present and disseminate their global cancer work to stakeholders. Has become a foundation piece of the ASGCR. Given the number of abstract submissions for the first time, we have scheduled 2 oral abstract sessions. So the 8 presentations today cover global cancer control across the cancer control continuum, from early detection and prevention to system strengthening. I would like to emphasize the overall strength of all the abstracts, and I encourage you all to attend the Meet the Abstract Author poster session. Abstracts will appear in the special issue of JCO Global Oncology this July. You are about to hear the high-level rapid-fire presentations, and additional study-related details are available in the poster presentations. There will be no question and answer discussion during this session. Instead, you can meet the authors at Thursday's interactive poster session on Gather to discuss or ask questions. You can find the full list of accepted abstracts on the event website under the poster tab. I am very excited to introduce the first speaker, Dr. Hassan Jamil. The first presentation is titled Examining Vaccine Attitudes, a comparative study of parents of healthcare workers and the general population in Japan. Dr. Hassan Jamil is a graduate from the Graduate School of Public Health, St. Luke International University in Japan.
Hello, everyone. Thank you for giving me this opportunity. So my name is Hassan Jamil. I'm affiliated with St. Luke International University and the National Cancer Center in Japan. If you can go to the next slide. So the purpose of this study, in 2013 in Japan, there was like a big crisis where like about 5 to 10 girls have some severe side effects of HPV vaccine. And this like side effects was picked up by the media and was presented as a viral story, and the general population was against it. And there is a lot of lobbyists against the HPV vaccination who supported this kind of narration that HPV vaccine is bad. And after this, the government stopped the recommendation of HPV vaccine for the teenage girls. After this, from 2014 to 2020 and 2022, the vaccination coverage for teenage girls were about 0. So girls who were born between 1996 and maybe 2004, 2005 have 0 coverage of against the HPV, which means there is a lot of increased cancer burden in the future generation. So on the other hand, like when the COVID-19 pandemic happened, Japan was one of the first countries who achieved one of the highest coverage rates, 80% for 2 doses in 2022. And now, until now, there is always the recommendation by the government for the 5th or 4th dose. So what we and now also the government have resumed the recommendation for the HPV vaccine program in 2022. Despite this, Japan still have a very low vaccination rate, about 30% compared to other first world countries like about 80 or like 90% like Ireland or Canada or other countries. So what I was planning to do is we were looking at some control group, and we chose the control group to be the healthcare professional. And we need a controlled vaccine or a reference vaccine, and we use the reference vaccine as a COVID-19 because it has high coverage. Can you go to the next slide, please? So the data source we have used the JAXIS survey, which is a survey that started during the pandemic to understand the people attitudes toward the vaccination, behavior during the pandemic, behavior toward the healthcare system in general. And we tried to compare between medical health workers and other population or the other occupational groups. So the outcome measurement, our outcome was simple. It's we have about eight questions about the attitudes toward vaccinating parents' daughters. So the question was asked to the parents and about their attitude. Would you vaccinate your daughter if the government told you? Would you vaccinate your daughter if her friend were vaccinated for HPV and COVID-19 vaccine in several situations? And the question was about Likert scale from like, I disagree, I strongly disagree, neither, agree. So we tried to make them as a score from -2 to +2. And we tried to compare between these groups. We made scale for COVID-19 vaccine and we made scale for HPV vaccine. And we compared the difference or how different the attitudes between the healthcare professionals and the general population for the HPV vaccine and the healthcare professionals and the general population for the COVID-19 vaccine. We just use simple t-test to do this comparison. Can you go to the next slide? So what we found was like pretty interesting that the population was, there is no significant difference in the attitudes toward COVID-19 vaccine between the general population and the healthcare professionals. So it means that the population have uniform attitudes toward vaccination. But regarding the HPV vaccine, we found that there is a significant difference between the medical workers and the general population. It means that there is a kind of divergence only when it comes to HPV vaccine, and the general population is not against the vaccination in general, but only against the HPV vaccine. Can you go to the next slide, please? So in conclusion, we need an urgent action needed because now it's 30% only in a population of 100 million. It means there is a high cancer burden in the future, especially for the girls who didn't get vaccine or were born in 1996 and after this. Our key insight is that specific hesitation about the HPV vaccine exists only, but not that there is a broad anti-vaccination in the community. There is like, if we compare the effort that was done from the Japanese government for promoting COVID-19 vaccine, it was pretty high compared to HPV vaccine. There was a lot of promotion in the media. There was like in the mail, in the TV, in the schools, and compared to the can you go back? And compared to the HPV vaccine, nothing like this was done. So if we talk about what action should be done, that we should use the healthcare professionals that already have a high attitude toward HPV vaccine to try to promote this among their primary, especially primary care physicians for the teenage daughters. Also, we have to work on educating about the misconception. Unfortunately, until now, there is a lot of conference for lobbyists talking about how the HPV vaccine is bad in Japan. And there is no such effort against this conference by the government. Also, we highly recommend using the reminder system and mail. For example, for COVID-19 vaccine, whenever the new vaccination appointment has come close, the government will send by mail a card for you to come and get your rodeo vaccination. And this doesn't happen for the HPV vaccine. Thank you very much. This is my presentation.
Thank you very much. And so next I would like to remind the audience that we will not have a question and answer. Please meet the abstract presenters in GatherTown for opportunity to ask them questions and discuss. So the next presentation is from Shailene Foley. It is on piloting a model for cervical cancer screening through community outreach and government capacity building in India. Shailene Foley comes from the American Cancer Society in the United States.
Good morning, good afternoon, good evening, everyone. As she just said, my name is Shailene Foley and I work at the American Cancer Society. And I'm very honored to be here today to share a bit more about a collaborative process for developing a model to improve cervical cancer screening in India. Next slide. So if any of you are on the scientific session that happened yesterday, some of these statistics may look familiar. The CEO of our primary partner in India that implemented this work got to discuss a lot of details about the implementation processes for this project. But the need is very high in India to address cervical cancer. 1 woman dies every 8 minutes of cervical cancer in India. And while the country has initiated efforts to combat this, including a recommendation for widespread screening of women ages 35 to 45, only 1 out of 10 women have been screened for cervical cancer in the last 5 years. And barriers to uptake of cervical cancer screening include gaps within the government health infrastructure, as well as social barriers like stigma around cancer and a lack of awareness of prevention and screening options. Next slide. So this project aims to address a lot of those barriers by developing a model for local cancer organizations in the country to support district health departments to improve access to cervical cancer screening, to strengthen policy around cervical cancer screening, and then in the community to increase awareness and reduce stigma of cervical cancer and cancer screening. So this project was collaborative in nature. The Cancer Awareness Prevention and Early Detection Trust, also known as CAPID, led implementation on the ground. Their team is amazing. Some of their representatives will be on the poster session later. The government of Haryana, specifically the Gurgaon District Health Department, collaborated on this project, and then the American Cancer Society provided technical support and guidance. Next slide. So the implementation for this pilot happened in 2022, and there were a variety of stakeholders engaged, including district authorities, public health centers and their staff, community health workers, which are also called ASHA in India, and local community members. The project had 6 core methods that were used to achieve its objectives. So first, CAPID worked to advocate at the district health department to get buy-in for supported community outreach and the hosting of government-supported screening camps, as well as to advocate for the inclusion of asymptomatic women in this project, as mostly symptomatic women are targeted for cervical cancer screening. Next was to train staff at the public health centers on how to administer cervical cancer screening using VIA. Then training of ASHA, they all went through day-long trainings in person around cancer, cervical cancer, symptoms, prevention, and how to mobilize communities around this issue. Following training of the ASHAs were supported to go out into communities to do door-to-door mobilization, to build awareness and have conversations with community members. These conversations then drove people in the community to these organized screening camps, which were facilitated through the public health centers in the targeted district and villages, but added cervical cancer screening as an additional service offered as a part of the non-communicable disease services already offered at these camps. Following the camps, CAPID worked to support counseling and navigation that was needed in the case of a positive screening result. So the outcomes, which you can see on the right side, I'll run through quickly. The project targeted 73 villages, trained 61 staff nurses at public health centers, trained 213 ASHA located within the targeted villages. These ASHAs worked to have conversations with around 170,000 members in the community, which then mobilized and brought in 5,653 women to receive cervical cancer screening, and then 91 women received support for a positive screen. Next slide. So overall, this project, which was more of a pilot, increased access to cervical cancer screening services. It enhanced the government providers' capacity to administer these services, improved community awareness of cervical cancer screening and cancer more generally, and programming was successfully embedded within the government health infrastructure. But going forward, sustainability and institutionalization of the processes that were set up will require firm government commitment and resource allocation. And then lastly, the work did not stop with this initial pilot project in 2022. This work laid the foundation for the development of an implementation guide last year, which is going to be tested and validated this year as the project is expanded to 2 new additional districts, and will work with 2 new local cancer partnerships, cancer organizations that CAPID will support to kind of replicate this model in other places. We truly believe this project sets the stage to work towards eliminating cervical cancer as a public health threat in India. And thank you so much for having me here today. And thank you to the amazing collaborative team members that have helped to push this work forward. Thank you.
Thank you, Shaylin. Our next presentation is going to be from Ms. Alia Rahman. The presentation is titled From Self-Collected HPV sampling to self-administered treatment, cervical pre-invasive lesions, a dream to reality. Alia Rahman is the acting CEO of Amplex Therapeutics Incorporated.
Good morning, everyone. Thank you so much for your generosity and for inviting us here. And thank you to my 2 colleagues, Drs. Lawals from Nigeria, for helping to support this project and research. Next slide, please. So the purpose of this presentation was to actually take a look at a decentralized approach to actually treating cervical intraepithelial neoplasia, also known as pre-invasive lesions of the cervix. Herein, I'll call it SIN. And, we drew from inspiration from the fact that cervical HPV at-home self-sampling has been shown to be as effective as clinician-collected sampling. So given the overall decentralized nature that diagnostics and therapeutics are moving, and, that ranges from digital health contraception to remote monitoring, our hypothesis was, would self-administered treatment of SIN actually be feasible? Next slide, please. So the methods, this is actually born from my own lived experience with chronic HPV and cervical dysplasia. I'm actually an engineer by training, not a doctor, but now here I am actually developing some pharmaceuticals. So I was 22 years old. Sorry, can you go back? I was 22 years old, otherwise completely healthy. I had a laser conization procedure following a carcinoma in situ diagnosis with chronic HPV 16 and 18, and I remained at the SIN1 to SIN2 grade for many years after the fact, for roughly 10 years. And I required a second excisional procedure. Well, it was suggested to me, but I actually refused the second time around and took it upon myself to conduct a desk review, which we'll discuss, to look at the feasibility of a self-administered topical therapy. And this was out of a desire to preserve fertility and, spare myself the trauma of a second surgery. So I initiated a desk review of historical treatment options and current advances that were happening in the SIN realm. And if you go to the next slide, we'll discuss the actual therapeutic options that were evaluated. So what I did was I conducted a pretty comprehensive review that took me a couple of years, looking at a bunch of drugs in development and also those that had already been explored clinically. And the most exciting to me when I was conducting this review, beyond, obviously the development of a therapeutic vaccine that has a lot of promise. However, there are issues in terms of it being cost prohibitive. And of course, that was not something that I could have developed myself. I looked at an ON study from 2003 that specifically explored the application of a compound known as EGCG, so epigallocatechin gallate, which is derived from green tea. It's actually a polyphenol of green tea, and it's already used in an FDA-approved drug for the treatment of HPV-induced genital warts called Verigen. And in this particular study, we saw that 74% of participants having SIN lesions actually experienced regression versus 10% in untreated controls. So what I actually did was I set out to compound my own intravaginal suppository using EGCG because of its favorable low toxicity profile, its possibility of low cost, and its very high efficacy potential. And as you can see here in this table, we reviewed a bunch of other drug compounds, but this one really won out in terms of its feasibility. But there were certain limitations in terms of it in its current state. So polyphenol E that is actually used in a Verigen, unfortunately, would have to be regulated under a Botanical Drug Act. And what we understood was that it would have to be refined to its purified form and then stabilized in order to become a commercially viable treatment that FDA would approve. And we needed to develop something that did not require refrigeration in order for it to be something that could be low cost, manufacturable at scale, and something that could be used in a variety of climates. So that's how my company Amplex Therapeutics was actually born, from this personal experience of mine. And now we are well on our way to hopefully obtaining FDA approval one of these days. We're in the pre-IND phase. And if you go to the next slide, we'll actually discuss some of the limitations that we discovered. So EGCG is very much clinically feasible. That was determined from this study, from this desk review. However, certain conditions have to be met in order for this to become something that women everywhere can use to resolve pre-invasive lesions of the cervix. So it must be low cost. It has to actually be muco-adhesive and stick to the actual cervix for appropriate localized drug delivery. And purified EGCG, unfortunately, auto-oxidizes rapidly. So we realized that innovation is required how to determine to determine how to stabilize the purified form to obtain the requisite approvals, as I mentioned. Moreover, it has to be stable at room temperature for varied climates and not require any refrigeration or cold chain transport. So these are all the things that we're currently solving for at Amplex Therapeutics. And I'm happy to announce that as of today, we actually have solved for pretty much everything that's listed here. So very excited for this drug to hopefully come to market in the next couple of years, and I'm happy to answer any of your questions in GatherTown. Thank you so much.
Thank you so much, Aliyah, for the great presentation. The next speaker that we have is Dr. Oluwatayo Adeoye. Dr. Tayo will be presenting on the global landscape of phase 3 interventional clinical trials in colorectal cancer. Dr. Oluwatayo comes from St. Elizabeth's Medical Center in the United States.
Thank you so much for having me. I'm excited to share a study on global landscape of phase 3 interventional trials in colorectal cancer, CRC. Special thanks to Drs. Bocco, Faladay, and Allen for their contributions. As we know, colorectal cancer accounts for about 1 in 10 cancer cases, with about 9% of all global deaths. In 2022, for example, approximately 2 million deaths. Incidence rates continue to rise, and fatality rates in low and middle income countries are also high. Hence, the purpose of this study was to examine the global landscape of interventional trials for CRC and focusing on 3 things, which were the trial characteristics, geographic distribution of trial sites, and predictors of premature trial termination. We utilized clinicaltrials.gov, which is the world's largest database for clinical trials. We focused on phase 3 trials, extracted data on all available characteristics, including trial designs, study sites, and predictors of termination, then performed a descriptive analysis comparing differences between completed and terminated trials, and analyzed the predictors of termination. If you look on the right, the flow chart shows we started with about 412,000 trials, and when we restricted them to phase 3 interventional trials focused on CRC, we found 556 unique trials. We excluded 125 after manual review and focused our analysis on 231 trials that met the criteria of either completed, terminated, or suspended for more than 1.5 years. Next slide, please. So the results of our study, with most of the trials analyzed were randomized controlled trials that focused on therapeutic interventions. Others focused on prevention, supportive care, and diagnosis. We found that the geographic distribution showed half recruited in Europe, about 1/3 in North America, another 1/3 in Asia. Notably, only 6% recruited in Africa. If you look at the graph, the orange bar shows the crude incidence rates per 100K in 2022, and the blue bar represents the number of trials. Some countries have been highlighted: USA, France, and China had the highest number of clinical trials in North America, Europe, and Asia, respectively. Canada showed higher crude incidence rates than the US, but had lower number of trials. And if you can also see trial activities low in African countries, and generally speaking, the graph highlights small number of trials in low and middle income countries. Next slide, please. So talking about the reasons for trial termination, we found that 17% of our 281 trials terminated prematurely, and participant accrual difficulties was cited as the most common reason. Other causes included financial reasons, administrative reasons. On the right-hand side of this graph, you can see we have a forest plot that shows predictors of termination. We found that industry-sponsored trials had lower rates of termination compared to non-industry sponsored trials. Trials with US sites had higher odds of termination than trials without a US site. Lastly, for each additional 100 patients enrolled, the odds of termination was lower. Next slide, please. Which brings us to our conclusion. The distribution of phase 3 interventional trials in CRC highlights that there's global disparities in trial access. Nearly 1 in 5 phase 3 trials terminate prematurely. This is not unique to CRC. This is seen in other cancer trials as well. This is an issue because it represents a barrier to innovation, wasted resources given the substantial time and the resources required of phase 3 trials. Trial characteristics associated with early termination included low number, non-industry sponsored trials, and trials with US-based recruitment sites. Overall, our findings highlight a pressing need for improved access to clinical trials in low and middle income countries and aligning trials with need. We need to do further research and evaluation of factors that lead to poor accrual and early termination of trials, and a renewed focus on clinical trial design to facilitate participation and also advance innovation. Thank you. I'm looking forward to meeting anyone interested on Gather tomorrow to discuss more and answer questions. Thanks a lot.
Thank you very much, Dr. Tayo. Our next presentation is Ms. and I apologize for mispronouncing your name, Ms. Kosile Dlamini. She will be presenting on the successful establishment of National Cancer Control Program and Cancer Registry in Eswatini. Lessons to inform NCCPs in low and middle income countries. Ms. Dlamini comes from the Ministry of Health in Eswatini. Thank you.
Thank you very much, Kosile Dlamini. Yes, from the ministry. Yes, my presentation is on the success that we experience as we're establishing the cancer control unit. Next slide, please. So the cancer control unit started after an assessment that was done by the IAEA impact review or assessment, which they normally come in different countries for the assessment. So we requested them to help us because we knew that from the cancer registry we have a high burden of cancer, but we didn't have a program that will help in prevention and control of the cancer. So they came in 2017 to do the assessment. And then the Ministry of Health successfully established the cancer control program. Next slide, please. So what we did, we initiated the development of the cancer control strategic plan after their review, because we followed their recommendations. So the NCCU, National Cancer Control Unit, it was initiated in 2019. And then we had the plan, which took us 5 years. So the program didn't have much of the officers, and we only had 3 personnel. But we, according to the plan that we wanted to have 18 personnel to implement. But what we did, we then, as a ministry, we then engaged with the partners who were there to support in the integration of some of the services in the programs that were available. For instance, in the HIV program, we then requested that we continue our cervical cancer screening and all the HIV-related cancers. So the team were able to be trained, and then we implemented that. There was a lot of collaboration, like I've said, with the intergovernment, ministerial, and then the public-private facilities. And we received some support under international partnership, which include the ICCP, which were ECHO ICCP. I think we get a lot of support in terms of the training. So, and also the learning and sharing with other colleagues who were part of the ICCP ECHO. So the National Cancer Registry was able to give us some information which relate to the burden of the cancer. Next slide, please. So when we implement the strategic plan, I think we were able to capture about 2,930 of our cancers, newly diagnosed cancers. And out of that, cervical cancer was 59.2, and then prostate 30, and breast 19. In actual fact, we have been running with the highest burden of cervical cancer since the 2015, where we established our cancer registry. So among those, we had about 4% of our children who are living with cancers. And there was a 31-fold increase in the number of cancer patients receiving chemo. So it means after we've done the implementation of the strategic plan, one of it was to initiate the chemotherapy, since most of our cases were referred to South Africa or private facility for care. But then I think one of the good news that we are noted as a country is the establishment of the chemotherapy, and we're able to increase treatment in the country from 52 to 1631 of our patients. So then we have seen the decline in terms of the referrals to the neighboring countries for care from 217 to 30. Patients navigators were initiated, and they were able to escort our patients from level of diagnosis to care. And we have seen that from 2021, and by 2022, we had able to link about 1,509 of our patients to care, especially from the rural areas where we have screened them. And then if there is some pre-cancerous lesions, especially in the cervical cancer or some lumps in the breast, we'll then refer them to the next level of care, where we did about 1,509. And then nationally, 1,041 health workers have been trained to provide cancer services, including palliative care. Before then, our nurses, they had only the information that they gathered when they were doing their formal education. But from this establishment, we were able to train more nurses for care, who were able to implement or provide cancer services in the different sites. And in the national rollout of adolescent HPV vaccination was initiated in last year in June. So now I think from 9 months down the line, we're about 63.6% of those young girls from 9 to 14 years enrolled in HPV vaccination. So as a cancer program, we're currently engaged in or done about 15 research protocols, of which 9 are utilizing the National Cancer. We're utilizing the National Cancer Registry data for students with for their MPH and PhD program. So it means the data that we have, we're able to it's being used by students and also in the MPH or those who are doing their PhD. Next slide, please. So in conclusion, I think we really want to appreciate the impact assessment that has been done. It has influenced or brought positive it positively influenced an establishment of the cancer unit and implementation of the strategic plan. This has led to the coordinated efforts in cancer prevention, diagnosis, and management, and also more cancer care needs met were locally. So whatever the two have been doing, it was mostly locally, not in the neighboring countries that we used to do while we were in the country. So we really want to appreciate to say the integration and also the availability of the, I think the ECHO ICCP, I think it has played a great role in the establishment and in the implementation of the cancer unit or the cancer services in the country. I thank you.
Thank you so much, Ms. Dlamini. And our next presentation is going to be from Ms. Gloria Kitur. Ms. Gloria Kitur will be presenting on health system strengthening strategies for improved cancer control in sub-Saharan Africa, a case of the International Cancer Institute's blueprint for innovative healthcare access program in Western Uganda. Ms. Gloria Kitur comes to us from the International Cancer Institute in Kenya.
Thank you. Thank you, Rahma. And hello, everyone. It's a great honor to be presenting to you about one of our programs. So as Rahma has mentioned, I'm Gloria and I work with the International Cancer Institute in Kenya. I would like to acknowledge my co-authors, Mr. Kwizera and Mr. Olodi, including Professor Chita Asirwa, who is also the PI of this blueprint for innovative access program. Next slide, please. So as a way of introduction, the International Cancer Institute in Kenya is a non-governmental and a not-for-profit organization. And we are based in the Western region of Kenya. And our focus is mainly on education, training, so capacity building of healthcare providers, on research and clinical care. And we do this by providing opportunities in cancer control. And we do this across the sub-Saharan African region through collaborative partnerships and even collaborations with other multi-sectoral players. With funding from Takeda, we have implemented the blueprint for innovative healthcare access. Blueprint Uganda is one of the blueprint programs that we run. And the focus of this program in Uganda was mainly to improve the access to screening and diagnostics, treatment, and even patient care. And we focused on three main cancers, that is breast, cervical, and prostate cancers, but still integrating other non-communicable diseases and mainly diabetes and hypertension and other hematological disorders. And the approach we took was a health system strengthening approach by working closely with the district health teams and also the communities, as well as the Ministry of Health in the country, that is the Uganda's Ministry of Health, and the partners. Next slide, please. So ICI partnered with two of the partners in Uganda, that is the Uganda Non-Communicable Diseases Alliance, as well as the Uganda Cancer Society. And we implemented two unique programs, but which are interdependent. And we did that, as you can see on the map, in the Western region, in 3 districts of Bushenyi, Mbarara, and Shema. And the 2 projects that each of our partners was implementing. One was on strengthening community awareness and screening for diabetes and hypertension, but then integrating the 3 cancers. And then the second project was on improving public awareness on cancer by building the capacity and advocacy for cancer control. Next slide, please. So for year 1, which was January to December of 2023, we had targets to achieve, and we focused on 4 main areas, sorry. So 1 on community advocacy, and we set out to reach 150,000 community members. And we, at the end of the year, we had actually surpassed our target. Also, we sought to train community health workers, train healthcare providers as well, and also conduct screening for the 3 cancers and incorporating diabetes and hypertension. And at the onset of these 2 projects, we conducted a baseline survey in 10 facilities in the 3 different districts, and we also interviewed 25 healthcare providers in those facilities. And surprisingly, only 2 out of the 10 facilities were conducting screening for all the 5 diseases. Some of them offered screening for either 2 of those diseases or even 3. And so a big gap was identified. We also went ahead and trained 30 media personnel on cancer reporting, and we've been able to present our work in different forums, including this one. And in conjunction with the Ministry of Health, we were able to conduct quarterly supervision visits to the 3 in the 3 districts, visiting the 10 facilities. Next slide, please. And so from our implementation in year 1, we identified as part of our key learning aims that the main strategies that would actually strengthen the health systems for improved cancer control in sub-Saharan Africa include 1, collaborative partnerships, using the ICI example, partnering with Uganda Cancer Society, Uganda Non-Communicable Disease Alliance, among other partners. And then secondly, capacity building of the existing public health system. So for the Blueprint program, our aim was not to create a parallel system actually in order to achieve cancer control, but strengthening the existing one and doing this by supporting the entire continuum of care, from awareness to screening, diagnosis, treatment, and even follow-up for the newly diagnosed cases. And then thirdly, providing access to resource sharing opportunities. I've just talked about capacity building opportunities and even research, establishing cancer registries, providing technical expertise to the partners on the ground, to the creating even the projects that support specific aspects of care, and even offering continued mentorship. And all this would be done with the aim of creating sustainable cancer control programs. So we are in year 2 of this program, and we hope to achieve even more on the aspects of strengthening the health system. Thank you very much.
Thank you so much, Gloria, for the wonderful presentation and showing us all you've been doing. We look forward to seeing the updates. So our next presentation is Dr. Biniam Tefera Deresa. Dr. Biniam Tefera Deresa will be speaking about collaborative action for public health, the Esophageal Cancer Consortium's approach to policy influence and capturing policymakers' attention in Ethiopia. Dr. Deresa comes from Adama Hospital Medical College in Ethiopia. Thank you.
Thank you very much for having me. It is an honor to be here. I will be presenting the activities we did on esophageal cancer in Ethiopia. to get a policymaker's attention and to be considered as one of the major public health concerns in the country. Next slide. The esophageal cancer was considered as one of the major public health problems, especially in certain areas of RC Valley regions, which are for long known as the hotspot areas. Esophageal cancer is not evenly distributed in the country, and there is a predilection and a selection of certain areas such as RC Valley area. However, this disease doesn't get the attention it needed nationally because of several reasons. One of them could be the disease awareness is generally low, and the risk assessment efforts, especially in the hotspot areas, were minimal. There was scarce diagnostic and treatment accesses for the marginalized rural areas that makes the visibility of the patient is less. Finally, there was no locally tailored treatment guidelines or training manuals for health professionals, which can help them to detect early and refer appropriately with time. One of the reasons for these things not available and not to be considered as a national concern was lack of the National Cancer Registry, which posed a problem because the only registry is located in Addis Ababa in the city, and which may not represent the entire country, especially in the marginalized agrarian areas. So in this process, we will present the collaborative efforts we did on this disease to capture the policymakers' attention and to make it as a public health concern that needs focus. Next slide. In this efforts, there were several individual and institutional efforts separately without a collective actions. To mention some, there was a PhD dissertation done by one of the scientists in the area to show the risk factors, but its advocacy level was still not well known because of the separate actions. There was also symposiums, conferences done on this disease, especially by certain hospitals and institutions in the regions, but that doesn't get enough attention. So to improve that, all the concerned bodies will be collaborated and come together and form the task force working on this deadly disease. The name of that task force was Southeast Esophageal Cancer Task Force, mainly constituting of the 4 institutions located in the hotspot areas as seen on this map. Mainly RC University, Adama Hospital Medical College, Madawalabu University, and the RC Nagale General Hospital was there. From abroad, also an NGO called International Oromo Health Professionals Association, IOPA, was also supporting this initiative with all they can. So this task force has been doing its work for more than 2 years. I will mention on next slide the achievement is. And finally, this task force was developed into a centralized consortium which can lead all the activities in a structured and organized manner. In this consortium, the research team, the advocacy, and the clinical team were the major arms that are working their activities. It is good to mention that in this effort, in the formation of consortium, there was not only the data and the scientific researches presented, but also there was a mass media campaign, the patient testimonies, and also engaging of the prominent individuals in raising awareness were also helped this consortium to get the policymakers' attention. Next slide. So the major achievements got from this task force later on from this consortium was the 2 big national conferences were held in Asala, Ethiopia in 2022, also in Addis Ababa, Ethiopia in 2023. We also able to develop the first of its kind esophageal cancer treatment guidelines and the training manual, which was not existed and as a country, which may help also the health professionals to get a reference and a training based on these manuals and to enhance the early detection in the early referral path. There was also the community education initiatives being done, and the community education tools were prepared, and there is still the media campaign and the advocacy are being done. The other achievement was the development and the implementation of the first of its kind short course endoscopy training and the equipping the hospitals in the area with equipment as they need, such as endoscopy. Above all, one of the key achievements was the government gave it attention with all these efforts, and a memorandum of understanding was signed with the Ministry of Health and the Oromia Health Bureau together with the member institutions of this consortium to work together on this deadly disease for the coming 5 years. It is also good to mention here, all these achievements were done by these consortium members without any payment, and everyone was doing voluntarily. Next slide. In conclusion, the collaborative efforts by individuals and institutions are crucial in conducting quality studies and also influencing policymakers to address the public health concerns such as esophageal cancer, which needed attention. And also these collaborative efforts are very essential to garner the national attention to reduce the burden of public health concerns such as esophageal cancer and to enhance the patient quality of life in Ethiopia. So finally, at the end, I will also call all the interested bodies to work with this consortium is welcomed. And for interactive sessions also tomorrow on the gather session, I am waiting. Thank you so much.
Thank you so much, Dr. DeRessa, for your great presentation. So next we will hear from Dr. Benson Nyambega. Dr. Benson Nyambega will be presenting on cancer data systems in Africa, a scoping review. Dr. Benson Nyambega comes to us from Western Kenya Cancer Care and Research Center. Thank you. Go ahead.
Thank you so much. Hello, everyone. I sincerely thank the organizers for this opportunity. I will be presenting today on cancer data systems in Africa. Thank you. Next slide. So ours was a scoping review. You must be aware, perhaps, that cancer registries are information systems designed for collection, management, storage, and analysis of data on individuals diagnosed with cancer. Most often, the gaps are around data collection, analysis, accessibility, and use. What we did was a systematic review of peer-reviewed articles, followed by a framework analysis. The period of review was 5 years between 2018 and 2023. 5 databases were queried, and our search terms were cancer registries in Africa. Next slide, please. So only 3 out of 34 of the African Cancer Registry Network Consortium of functioning population-based cancer registries appear in our search. The bulk, 6 out of 9 registries, are facility-based. Now, the major challenges were around data collection, and we cite coverage, resource and organization, staffing, and we cite issues around training, attrition, data quality. So we come across issues of missing data, duplicated data, and inconsistencies. Healthcare infrastructure, so basically infrastructure for diagnosis, infrastructure for treatment, platforms for cancer registries, and in the area of policy, we cite policy development and implementation gaps. On diagnostic and treatment limitations, we cite issues around people not being aware of the different types of cancers, knowledge around cancers, and consumables that are needed to control or treat cancer. Next slide, please. So on conclusions and recommendations, we realized that the challenges that we pulled out are interconnected, and addressing them requires comprehensive strategies, but mostly around policy and funding. Now, opportunities are abound and they revolve around collaboration. So collaboration is key. Technology adoption is inevitable, and because African populations are ethnically diverse, ethnic specific interventions come in handy. Risk and important epidemiological research and milestone setting based on research data are important for quality control. Next slide. I sincerely thank my colleagues, Lilac, Lorraine, Edwin, Victor, Solomon, Eleanor, Katie, Andrew, and James for a wonderful job and for support throughout this work. Thank you so much.
Thank you very much, Dr. Benson Nyambega. We have heard from presenters from 5 countries and covering 4 areas of the cancer control continuum, from vaccination all the way to survivorship and control. And highlighting this year's theme, collaborating for impact. We invite you to find these presenters as well as other accepted abstract presenters on Gather Town on Thursday. So now we will transition to the interactive poster session. Please leave this Zoom and join us in Gather Town, where you'll be able to view additional posters. The interactive session will last until 10:50 a.m. Eastern Standard Time, then you should be able to rejoin the Zoom for the scientific session titled The Impact of Cross-Cultural Collaboration on Clinical Trials, Successes in the U.S. Latin American Caribbean HIV and HPV Cancer Prevention Clinical Trials Network. So we look forward to seeing you there. So please feel free to transition to Gather Town. Thank you all. Thank you to our presenters.
Okay. Hello, welcome back, and welcome to our session, The Impact of Cross-Cultural Collaboration on Clinical Trial Successes in the U.S. Latin American Caribbean HIV, HPV Cancer Prevention Clinical Trials Network, also known as ULACNet. I am Emma Brofsky from the U.S. National Cancer Institute, Division of Cancer Prevention. I'm going to give a short introduction to our network, and then I will ask some questions to our 7 panelists who work on implementing studies in our network and are excited to share their diverse perspectives with you today. As a reminder, the panelists will be speaking in multiple languages, so please be sure to select the language you wish to listen to in the globe interpretation icon on your Zoom screen. So what is ULACNet? The U.S. Latin American Caribbean HIV HPV Cancer Prevention Clinical Trials Network, ULACNet we call it for short, is an NCI-supported clinical trials network. It is a cooperative agreement U54 mechanism with 3 partnership centers, which are made up of a US-based lead organization and several affiliate organizations in the US and Latin American and Caribbean region. Our overarching goal is to develop evidence to improve and optimize prevention approaches for HPV-related cancers, specifically for people living with HIV. People living with HIV are now living longer and healthier lives due to increased access to antiretroviral therapies and better overall health care. individuals living with HIV are at risk for developing cancers related to human papillomavirus infection, or HPV for short, including cervical, vulvar, vaginal, anal, and oropharyngeal cancers. We hope that what we learn from the studies in this network can be translated into future guidelines and policies to improve health outcomes for this population. The LAC region has many opportunities to participate in this work because of existing partnerships, infrastructure, and support for research in the region. As a very ambitious new network started in 2019, 9 studies were planned to be completed over a 5-year period. 5 studies have been implemented despite the challenges of starting this new network and the setback of the COVID-19 pandemic. These studies are focused on HPV vaccine dosing and new indications, novel screening and triage strategies for anal and cervical HPV, and precancer treatments. This is a high-level view of the program structure, showing the 3 partnership centers in the ovals, known within our network as Campo, Rocha, and Colaboración Vita. And they are, as I said, composed of US and LAC partners, and they're supported by a management team here at the NCI Division of Cancer Prevention. And there's a coordinating committee made up of the principal investigators who make some of the scientific decisions for the network. There are also several different entities that provide programmatic support and partnerships from other offices inside of NIH and outside, and some cross-network working groups and activities. So we have 5 open studies in ULACnet, 5 clinical trials that you will hear more about. But to give you an overview, we have study 201 is a placebo-controlled trial that aims to prevent persistent oral HPV infection in men living with HIV using the Gardasil vaccine, and has completed enrollment of 700 participants in Mexico, Puerto Rico, and Brazil. Study 301 is also using the HPV vaccine in children and adolescents living with HIV. And the goal is to determine the optimal number of doses for these children, as there is currently no clear guidance, no clear guideline for this population. This study has recruited 95 children and adolescents, 26 of which are from Peru, 51 from Haiti, and 18 from Brazil. We also have 3 studies that are focused on screening. So study 101, 202, and 302 are all looking at different combinations of HPV testing and triage strategies in women living with HIV to identify cervical precancer, and also for men living with HIV to identify anal precancer in study 101. Study 101 has recruited over 1,000 men and women living with HIV in Mexico and Puerto Rico. Study 202 has recruited almost 200 women in Brazil, and the team plans to open the Mexico site soon. And study 302 has recruited over 600 women in the Dominican Republic. I wanted to give a bit of an overview geographically of our network and a preview of the panelists that I will introduce in a few moments. In the United States, we have organizations in New York, Florida, Washington, and California, and of course, the NCI located in Maryland. In Latin America, we have clinical sites in Mexico, Brazil, and Peru. And in the Caribbean, we have clinical sites in Puerto Rico, Haiti, and the Dominican Republic. And we have speakers from almost all of the countries that are represented in our network today. I also wanted to highlight that it takes all different types of people and partnerships to run a network like this. And this graphic shows a lot of the roles that people in our network perform, from clinical roles and technical roles to more coordination and laboratory staff, really a diverse group of people. As well, we wanted to say a thank you to the participants in our studies, because we could not do this work without them, of course. I wanted to touch on a few network-wide initiatives to increase cross-cultural collaboration. We have an initiative called United, the Unified Network to Enhance Community Dialogue and Site Education. And we've held several webinars on community engagement topics, also in collaboration with other HPV networks and groups at the NCI. We provide opportunities for emerging investigators to present their work at our annual meetings. And we've had a virtual poster session last year. We have supported early career researchers in the network with supplements and other opportunities. We try to be inclusive in our meetings, which have been held virtually or hybrid, and often include live language interpretation support, to engage people across the Latin America and Caribbean who may have a preferred primary language that is not English. We have a newsletter that takes submissions from network members and is available in 4 languages on the Division of Cancer Prevention website. And if you are interested in United or the newsletter, you can scan the QR codes on this slide. And our panelists will talk about many of the challenges and lessons learned in the network beyond these. Just wanted to highlight some of these efforts. So now I'd like to introduce our 7 panelists that we have today. We have Francis Vasquez Sanchez, a research scientist from the Comprehensive Cancer Center in Puerto Rico. We have Betania Allen Lee, is a professor at the Instituto Nacional de Salud Pública in Mexico. We have Kaike Mello, is a program manager at Weill Cornell Medicine in New York in the US. Delia Pinto Santini is a research associate at the Fred Hutchinson Cancer Center in Seattle. Giovanna Teixeira is a sub-investigator at the Fiocruz Foundation in Rio de Janeiro, Brazil. Jessica Gutierrez, a study coordinator at Via Libre in Lima, Peru. And Vanessa Rouzier, research site leader at Gescio in Port-au-Prince, Haiti. So we look forward to hearing about their diverse experiences, and we have a few questions to ask them. So if they are all highlighted on the screen, I think that they are. We can start with our first question for the panelists, which is, what were the biggest administrative and operational challenges you faced to implementing ULACNet clinical trials? And first, I'd like to ask Vanessa from Haiti to give some remarks on this question.
Thank you, Emma, for the wonderful introduction and for the opportunity to participate. It's such a diverse group, and it's wonderful to collaborate. For the Haiti site, because of the COVID pandemic pause, there was a need to add another site to the optimal trial. So including a new international site as the study was already ongoing at other international sites was a major challenge. So administrative delays were very long to onboard the Haiti site, and it took over 1 year. That was unexpected, and it took a lot of discussion from with the NCI, with the Fred Hutch, and with the Haiti team to onboard the Haiti site. And this was unexpected for us because we've been collaborating and doing NIH-funded research with NIAID. This was our first partnership with NCI, but we've been doing NIAID-funded research for over 20 years. So while there was experience, it took a lot of time for NCI and other partners to approve the Haiti site. So I think the challenge for us was that, and for all partners, was that this delay caused a lot of concern from the budget and from the accrual point of view. And I think the lesson learned while we managed to get through it was that administrative preparation is an important aspect for international partnership and collaboration, as well as technical site preparation. I think we often focus on preparing the site technically and making sure that there is site capacity. But I think at the US level, for that kind of international and global collaboration, administrative work is also needed. But we're happy that we were able to onboard the Haiti site and complete enrollment in 6 months, which allowed to at least wrap up enrollment for the Optimal study. The other set of administrative challenges was, the reimbursement process. I think Fred Hutch also had a lot of work to do, and I know Delia might want to comment on that, but there was a lot of delay basically in being able to provide payments and the sub-awards on a timely fashion, which was difficult for the Haiti site to be doing the work and then getting reimbursed in a very delayed fashion. But these are my points, I would say. Delia?
Thank you, Vanessa, for sharing. I'd like to ask Kaike to provide some comments on this question as well.
Sure. Thank you, Emma, for inviting us to speak. I guess what I can say is that I'd really credit the contributions of our administrative and operational functions across all of our teams for really helping to push the wheels that move forward the progress of the research that we're doing in other countries. I've had experience in the past working on different kinds of research projects, but this was definitely the first time I've ever had to manage a project, not only of this scale, but also in an international setting. With that came a range of challenges and new experiences that I never anticipated. One of our biggest rate limiting factors in sticking to our project timelines even has been just getting the necessary regulatory approvals and equipment procured to our sites that they've needed for their trial startup. For our vaccine and screening studies that you mentioned earlier, where we're working with foreign sites in Mexico and Brazil, it's been particularly challenging to translate both literally and figuratively the required study documentation that we need to be able to adhere to the standards not only set by the governing bodies and scientific and ethics review boards that are on not only on an institutional level, but also on state and federal levels as well, in a way that one is consistent across all of our sites, two, that complies with the NCI federal regulations, and three, that is completed in a timely manner. So in a similar fashion, even in procuring and shipping study materials and biospecimens, which my colleague will speak on a little later in this panel, but we've had to jump through many regulatory hoops to ensure that we comply with federal export regulations. In fact, it took us over a year to get the necessary approvals to ship a specimen testing device that before that even took long to first negotiate on its purchase. And we only just now got it received by our sites early last week. Even to some of our own domestic sites, it's been a learning experience for myself on how to properly label and document the exact specifications that are needed for the shipment of goods that are considered quote unquote medical devices. It's been a lot of trial and error in this regard, and it's shown that there are a lot of gaps in country-specific public-facing resources related to the operational implementation of global health research here in the US. Something that I hope I myself and others here can use what we've learned in our personal experiences and share them on platforms like this symposium to aid in hopefully the advancement of future global health research. Because especially in these cases of large multi-institutional trials, particularly in global settings where we as large teams are collaborating remotely, oftentimes on different media channels, different time zones and languages, I think that this imperative falls largely on the administrative and operational management to help liaise and facilitate the communication collaboration and cohesion, not only within our direct groups, but more broadly as a network, which is something I think this panel shows that we're actively striving to build on.
Thank you very much. Our next question relates to a topic that I know can be challenging for anyone in any study, but particularly in settings where we are working with this particular population of people living with HIV and in some under-resourced settings. So the question is, describe some of the successes and hurdles in recruitment and retention of adults and children living with HIV for HPV prevention studies in your country. And we have some examples here of some of the recruitment materials. So first, I would like to ask Betania if she can talk about her experience in Mexico.
Yes, thank you, Emma, and thanks for everyone for being here. So I work in the Rocha consortium group at the Mexico site, where we are working on the vaccine, HPV vaccine trial, where men and some transgender women are randomized to either vaccine or placebo. And we're about to start the screening and triage trial for women and trans men living with HIV. So one hurdle that we had was extending the length of the vaccine trial. So this meant that our participants have to wait longer for the trial to be unblinded. So they know, of course, they have given consent to receive either placebo or the vaccine, and they know that they will only be told whether they did get the vaccine at the end of the trial and then receive the vaccine if they got the placebo. And that's one of their main motivations for participating in the trial, is to get this vaccine, because in Mexico, men living with HIV do not have the HPV vaccine available to them. So we were very worried when we had to extend the length of the trial that our participants would not be accepting of this. I think that because we had a very close relationship with our participants, we check up on them, we refer them to care if they're having a problem. We don't actually provide their care, but we try to channel them into care if they need it. And we're always checking up on them and explaining this study to them. And so I think that helped for them to accept that they would have to participate in the trial longer. We also had to increase the sample size. So that was also an issue. Sometimes the size of the actual space that a clinical site provides to us can be very, very small. So we have 2 clinical sites in Mexico, and in one, the area where we work is very, very tiny. It's a little tiny office, and there is no waiting room area because of the COVID pandemic. People cannot wait inside. So we cannot have people waiting. We cannot have overlap on appointments for people's visits to the study. And we have to organize everything so that we don't have a whole lot of samples. So after each person's samples taken, those samples are transported back to the lab because we just don't have any room in that site. In the other site, we have more room. So that can be sometimes easier. Also, the workload that healthcare personnel have at the clinical sites can be a really, really heavy workload. And so that can mean that they just have no energy or time or mental energy to recommend our study. They are not against us doing the study, and they understand the importance of the study, but they just have too much to do to support us referring participants. So that can be a big hurdle too. And you just have to understand that their workload is so great and that this is not their job. It's our job to recruit. And if they can't help us, that's just their situation and it's nothing against us. And you just have to do the work that's necessary and not expect them to do something more than they're already doing when their workload is so great. I think some successes that we've had have been a strategy that we use is very, very thorough pre-screening before the initial visit. So using WhatsApp, sending lots of different information, making sure that men are really eligible and that they really are interested in participating is really, really important, because otherwise we waste these people's time if they're ineligible. So we never want to do that. We also keep very detailed local records about ineligibility, because some aspects of ineligibility can change. So for example, how long a person has been taking their medication can change. And so then they may be able to be invited to the study when they were ineligible, maybe a year before. And of course, always providing compensation to participants is really, really important. As Emma said, they're the reason we're able to do this study. Thank you.
Thank you, Betania. And now I'd like to invite Jessica in Peru to speak. And as a reminder, she'll be speaking in Spanish, so choose your language accordingly. Jessica, por favor.
Thank you, Emma, and good morning. I am Jessica, the coordinator of the Via Libre study. It has been one great experience for me, very gratifying, very pleasing as the coordinator of recruiting. Currently, I work as a coordinator of this study. We have two scenarios for recruiting and follow-up. Our obstacles in 2020 and 22. When we were preparing the study, we had 100 children from 8 to 12 who had been diagnosed with HIV. They were receiving treatment and care in different hospitals in Lima. There were some regulations for the registration in Peru. QUAC requires to have authorization for both parents. If they die, the parent had to present a death certificate in case that the parent lost the custody of the child. They would have to show a document sent by a judge. This it meant that the first list decreased to find possible participants. Sometimes the father had disappeared or couldn't provide authorizations for the child to participate. There was a group of children who had been treated in our hospital. However, they had been raised by family members and had no documentation to assign custody of the child. There were 6 children under the custody of protection entities, and that was a problem for us because we weren't able to recruit these children into our study. There were a few cases with children whose parents work who were not available to come to the center. Sometimes a parent would come, sometimes the next day the other parent would come. So it was hard to get authorization to enroll the children. Successes. We were able to enroll 28 participants in our center. We use digital tools, for example, the National Registry of Identification, known as REMIE, in case a parent did not have the document, the death certificate. This way we could enroll and have the participant within the study. We've used recruiting strategies. We called and explained to parents what the study was about. Also, we invited family members or friends who may have been interested in being part of the study to the group of children that did not live with HIV. That way, our participants could come to the visit. We also called 7 days before the date of the meeting and also 24 hours before the actual appointment. In order to continue the follow-up and not lose touch with these children, we are using the system of calling them every 3 months in order to update their contact data, find them, and ask how they are doing health-wise. So far, there's only been 1 visit outside that window. The reason is because the parent had an accident and did not allow the parent to bring the child for his visit. Another challenge throughout our clinical study is that because of the health ministry, there has been this strategy that is implemented, vaccination strategy. The Ministry of Health is vaccinating children at home as well as in education institutions. The center has therefore implemented calls that we made every 3 months and mentioned to the parents that it is not necessary to receive the vaccine by the Ministry of Health because they have received it in our center. In 2023, we were invited to look at the work plan for vaccination against HPV by the ministry, and we had to rethink our strategies, which led us to have a letter by the sponsor to be sent to the education institutions to mention that the children have already gotten the vaccine and is participating in our clinical study. Parents have also sent a written sworn statement to their teacher saying that they do not want the ministry to vaccinate their children. Thank you so much.
Thank you so much, Jessica. Muchas gracias. Now I'd like to ask Vanessa to speak about some of the successes and challenges that they've had recruiting for the same study, 301 in Haiti.
We were very happy to be able to finally be onboarded and to start a recruitment in the study in June of 2023. And there was a lot of pressure for the Haiti site to quickly enroll participants because there had been such a delay because of the COVID pandemic. So within 6 months, we were able to enroll 51 participants and the enrollment stopped. And this was very rewarding and very satisfying. However, this was happening in a very difficult time for us in Haiti. Implementation and conducting research has been very challenging because there's been escalating political turmoil over the past 4 years. And it's actually culminated in civil war-like conditions currently over the past 3 months. We have a state of emergency that's been proclaimed by the government. There's been a coup with the acting prime minister that's been ousted, and there's been a very long delay in establishing a transitional government. There's an ongoing curfew in the country, which limits our operational capacity and the times that we can work. And additionally, there's been a lot of violence in the country because of the political turmoil. The capital is kind of controlled by heavy gangs. So that has led to an important population displacement and migration from the capital to the provinces. What this translates to is that eligible participants or enrolled participants had to abandon their homes frequently and change locations. So, when you have a steady participant, being able to keep in contact with them is essential, obviously, not only for recruitment purposes, but for retention. So while it's been obviously very difficult and very challenging, JESCO, the center where I work, is well experienced in conducting research in difficult settings. As you know, Haiti is a country that is plagued by natural catastrophes. We had the major earthquake in 2010, the largest cholera outbreak in that same year, but also political turmoil for many years. So we have an ongoing contingency plan that is updated after each new challenge. So for the 301 study, we've just had to update our contingency plan. And one of the ways that's been important was to change or adapt the way we contacted our participants. Not only do we do, like Jessica was describing, phone calls to our participants to reminding them of upcoming visits, but we do WhatsApp communications. We provide phone cards or phone minutes to our participants so they can reach out to us, especially when they've had to move. It's usually very precipitously, leaving and abandoning their homes and their material possessions. And having this ongoing relationship, one of the advantages at the JESCO site is that the clinical care center where our participants receive their HIV care is at the same location where the clinical trials recruits as well. So the staff has this long-standing relationship with our participants, which make it that they trust us and they keep in contact with us. So even when they've had to move and we lose contact with them by phone, a few days later, when it's safe, they come to tell us that they've moved, and they keep in touch with us. And they've been very proactive at keeping in touch with us, which has allowed us to have 100% retention. And only one participant had to have a visit for blood collection outside of the window because of insecurity, and she couldn't leave her neighborhood in time during the window. Because of this situation, we've had to provide, JESCO's had to provide additional support for families as well, because this is an unprecedented time for us in Haiti with the violence, with inflation, with the economic situation. We've had to provide food kits to help our families, and we've seen weight loss in our participants as well. School fees, school support, a lot of psychological counseling for our participants who've witnessed traumatic or violent situations. So these have been some of the strategies that we've had to implement to do the recruitment in these very challenging times. But I think the resilience shows that this is definitely feasible. And research is often an important means for participants to access clinical care that is otherwise not available. Like Betania was saying that the HPV vaccine is not available for men. In Mexico, often research provides a clinical opportunity for participants. So being able to conduct research, even in difficult settings, and I think Haiti is not the only one, there are violence in other places and other hurdles, it is a very rewarding and definitely feasible, and we appreciate this partnership and the ability to continue. We've also continued in our other clinical trials for HIV, tuberculosis, malnutrition, and it just shows that the partnerships, while they need to be adapted, can be very successful. Thank you.
Thank you so much. Our next question is, what were the lessons learned for laboratory and pharmacy requirements at your sites? And I'd like to invite Delia to speak about her experience in her group with the studies that they're working on.
Thank you, Emma, and thank you all the ones that were before me. So I worked directly with the trial on vaccination for children living with HIV that Vanessa talked a lot about, and Jessica too. And as part of the network, we also work with this other study called Oportunidad that is in the DR and is in women living with HIV. And I'll tell a little bit about the lessons in that study too that I got from our friend Angelica Mondragon, who is not part of the panel today. So I think the lessons for, I'll start with laboratory. I have to say that when we collaborate with these sites, we are actually, it's great that we can collaborate and there are already structures established at the sites. So there are laboratories in all these sites that are already working, that have their infrastructure, that have experience. And for this network, basically one of the first things is to onboard the laboratory. So that was one lesson, is to know, for example, when we were requested certification for these laboratories that are not in the US, it was expected that we had like CLIA certification, for example. So for me, I started few years ago on this, it was like a surprise because the sites won't have CLIA, most of them won't have CLIA certification, but actually CAP certification, which is another one. So things to keep in mind when, you know, people in the US maybe are expecting CLIA certification, but then they get another one and there is always a back and forth, right? On like, oh, what is this? Are they really certified? Are they of quality? And, you know, all these things that sometimes we doubt, you know, the ability of sites, that because maybe there are middle income countries or low income countries, we sometimes doubt, right? But we all solved it and we all understood it's part of learning how to work interculturally. So that one big lesson is to be ready to know that the certification for mother labs may not be the ones, that are common in the US, but that doesn't mean that they are not good and valid. Instead of, for example, knowing also like quality of the specimens shipped, we were very lucky because most of our sites are experienced sites that were already in HIV clinical trial network. So they had information about the quality of, for example, PBMC preparations. So it was kind of it was great to be able to use those resources because we knew how the sites were doing in these other certification programs. So we could save some time to say, okay, they are qualified, they know what they are doing, they're getting good quality PBMC. So there was it was great to kind of save time in that regard. When the samples came here, we again did quality certification in our sites, but it was good to know that the sites already had certification from other experiences in the past. One thing that was challenges were like for a laboratory, for example, for a specimen tracking. Most of the time we use here electronic systems that are actually expensive, like the software for tracking specimens is expensive and it was not included in our budget at the beginning. So some of the sites couldn't use the tracking system that they use for other networks that pay for the system, and they couldn't use it for our network. So we had to create an in-house kind of red cap based tracking system, which worked fine. But then we needed to also create labels that needed to be sent to the sites. So we needed to just, we have the resources to do it, which is great, but it's something also to keep in mind that, those are expenses that sometimes you don't include initially in the budget, and then, investigators have to find funds and from other sources. In terms of, for example, for Haiti, we had the challenge of flights that were canceled. So we had to basically wait for specimens to arrive because the specimens couldn't get out of the country. These are, things that don't happen usually, but it happened and you just need to go with the flow. That's the lesson. The site is really resourceful, as Vanessa said, and sometimes when there were delays on like there was no dry ice coming in, actually they were even ordering dry ice from the US to get it in the country to get the specimens out of Haiti with that dry ice. So it's like the lesson is, I guess we work together to make things happen. That's the biggest lesson for, and in terms of pharmacy, I'll say, well, it's always important to think ahead of time in terms of relabeling and how the shipment of vaccine or other treatments will need to get into country. For us, as Vanessa mentioned, the vaccine, the HPV vaccine that we are using, the Gardasil 9, was not available in Haiti. It was already approved in Peru, and it was approved in Brazil, but it couldn't. But we needed to import it anyway because it was mostly in private sites that it was available in private pharmacies. So there was like 3 different sites with 3 different requirements to get the vaccine in. So. For example, for Peru, we knew so we could get the vaccine from the country, so we didn't need to think about importation, and they could basically relabel it there. In other places, we have to find a second party to relabel the vaccine and also shipped. And this relabeling and shipment was not initially funded by the provider of the vaccine, so that was a different bulk of the budget that we needed to think about too, that was not initially thought of. So there are so many players in moving things for laboratory and also for pharmacy that you basically have to sit with the sites. The biggest lesson is to sit with everybody that actually will touch these things so that you can find, okay, what is needed ahead of time, like do kind of a map of all what is needed early in the process so that you are not kind of putting up fires when you are ongoing. That will be my lessons.
Thank you so much, Delia. I'd like to invite Betania to add some more remarks from Mexico.
Thank you. I'll try to be brief so we can have other participants. In the Rocha Consortium in the Mexico site, we have our laboratory, and it's not at the 2 clinical sites. So when you're doing randomizing and then transporting the vaccine, it can be complex because at the site, we have one site that's 30 minutes away and one site that's about 2 to 2.5 hours away. So if at the site you don't have space for your pharmacist to be doing the randomization and then distributing the vaccine, we have to have the randomization done at the laboratory and then transport each vaccine randomized for each participant right when that participant is coming into the study. So that can be complex to organize. Keeping vaccines at the clinical sites is not feasible, either because there's no space, or their electricity backup can be not as well controlled. So you would have, you could possibly ruin your vaccine and have to replace it. And it's more difficult to ensure that their refrigerators or freezers are calibrated. So we can't store anything at the sites, including vaccines, even just for a short period of time. So we have to organize everything with the transportation from the sites to the lab and from the lab to the sites. The equipment for sample analysis at the sites can be limited, either because they don't have it or because we are not allowed to use it. Because they're using it for their clinical care. So you have to transport the samples back to the laboratory, and then after a long day of field work, then have the sample analysis done. And there can also be problems, not so much locally, but with shipping samples to the biobank. And so we've had really good relationships with the institutions in the US, which have supported us in whenever we've had shipping problems. Since biobanking is really important for the future. Thank you.
Thank you. I think we've heard a lot of really great responses and lessons learned in all sorts of ways, which will bring us to our last question before we hopefully have some time to open it up to your questions from the audience. So our last question is, how do you see your cross-cultural partnerships contributing to the sustainability of your sites for future research? So after all that you've learned working together in the US and other countries in Latin America and the Caribbean, we'd love to hear from Francis in Puerto Rico about your experiences.
Hi, yes, I'm part of the Campo Consortium, which is California, Mexico, and Puerto Rico. And there has been challenges, but it's definitely good to end this with a happier note as how we were able to benefit from this hard work that we have been doing. And as part of the Campo Consortium, another study was created that allowed us to see oral HPV prevalence in our population and other risk factors. All the members of the consortium joined together under the direction of our sites, and the infrastructure that was already created for the screening studies was used to submit a new proposal. Although we were not able to get the proposal through the mechanism that we wanted, we were granted some funds to carry out this study as a little pilot for a year with great results already. We have recruited over 2,000 participants, which has been great at all our sites. And using the labs, the agreements, the collaborations, and all that has been created within this network, this study is being carried out in UCSF in California, and Mexico, and the Instituto Nacional de Salud Pública, and INCAM Instituto Nacional de Cancerología, and also here in Puerto Rico in the Comprehensive Cancer Center. Also, as mentioned by Emma, our study, ULAGNER 101, is about screening procedures preventing cervical and anal cancer, which include high-resolution endoscopy. This is a relatively new procedure, and we still have a lot to learn about anal cancer prevention. Given the limited number of providers trained in HRA, the doctors that have been trained within the campus studies will be key in the future studies that require this procedure. So we were able to train physicians to carry out future studies too. Also, cross-cultural comparisons will increase our understanding of anal and cervical cancer and co-occurrence and prevention within the context of different regions and different cultures. We know that sometimes what we see in one, even if in Latin America, what we see in one country is not what we see or the results we expect in similar countries with similarities. So it is definitely great to use what we already created to see how we can improve science and keep working on this.
Thank you so much, Frances. And now I will turn it over to Giovanna to speak a little bit about Brazil, and she will be presenting in Portuguese. So just a reminder to choose your language.
Good morning. I am Giovanna. I work in pediatrician. I work in Fiocruz in Rio de Janeiro. I would like to thank you all for inviting me to be here. We see that all the partnerships is necessary for all the collaboration. But here in Brazil, we see inside of our country differences. I'd like to share this knowledge and to share this knowledge with other countries. It's a challenge due to the problems that we have with the researches and the results and the innovations. This collaborative work increase the research. It's very important, this collaboration, this partnership. And of course, we're very grateful to share this knowledge. And like to share here in this panel that I could see that hurdles are also presented by other colleagues from other countries. So it's a relief to know that we're not the only ones and we share the same problems. Sometimes we have an activity that was very well done here and we can share with you all. And we also want to hear from you. This multicultural collaborative job increase the value of the research and the relationship among us, among the professionals. It goes beyond the results of the clinical trials.
Okay. Thank you so much, Giovanna, and to all of our panelists. And it seems we do have a few minutes for some questions. So please feel free to put questions in the chat for any of our panelists or in general, and we'd be happy to share more with you in the last few minutes that we have. While we wait on that, if there is anything that any of the panelists want to comment on that they heard another panelist say or that they'd like to share.
Maybe Emma, I can add, any collaborations and global research is wonderful. Obviously, it can be very challenging and there are always lessons learned that we can improve. So I think, sharing those lessons learned so that different networks don't have to reinvent the wheel every time. But obviously to say that, collaborations are sought out, and global research is important to allow geographic representation so that, some of the answers that we're looking for apply to the populations where they're going to be used for. So I just wanted to say thank you for all the different partners, and definitely for Fred Hutch for all their support.
Thank you, Vanessa. We have a question in the chat. How can these collaborations be extended to other parts of the world? I don't know if anyone wants to take that. I can also take a moment to give a plug. We have another NCI, Division of Cancer Prevention Network, that has a global focus on HPV cancer prevention in people living with HIV, and that is called Cascade. So we have a lot of cross network activity. So that's another way to extend to other parts of the world. But if any of the panelists want to comment on that question. Or maybe everyone's focused currently on where they're currently working on. But I think a lot of the lessons are applicable widely. There's another question in the chat. How can we address attrition in research studies in conflict settings in LMICs?
Maybe I should take a stab at that one. This is probably for Haiti.
For sure.
Yeah, I think you want to work with institutions that have established track record in conducting, whether it's clinical care or research, in conflict settings. And conflict doesn't have to be the whole country's in conflict, but some cities have high gang violence in many cities in Latin America, whether it be Brazil, Mexico. And I think it's important to reach out and listen to what the local expertise is, because people know how to function in this setting. It's very different, obviously, than functioning in the US. But I think listening to partners on site and trusting them to be able to do so. I think for us, we have 100% retention, and we haven't had, while it's difficult and it's incredible work on part of the local team and the staff, because of our experience, I think we can continue to conduct research in very difficult settings. I don't know if the other partners want to comment, but I think that it shouldn't be a deterrent for research. If you can partner with a site that has a good track record and good experience, then that should not be a deterrent for collaborating with LMICs, even if there's conflict. Obviously, it requires flexibility, but I would say it's definitely feasible.
Mm-hmm. Thank you, Vanessa. I would agree. And I would say that's also a lesson learned here at the NCI is being flexible and patient with our LMIC partners. And, we trust that they know what's going on in their local sites and that they'll report back to us and that they'll ask for assistance when needed, and that working relationship that we've worked so hard to establish. I see another question about language being a challenge in some of the networks, and how did people adapt to the language and multilingual experience to promote collaboration in non-English dominant countries? Maybe one of our panelists want to take that. I know there was a lot of translation, a lot of translating of recruitment materials and documents and trainings in other languages, but if anyone wants to give an example.
Yeah, I think that's often been an issue, and Heike is probably going to say something similar, but even for us, I think just even learning the financial language for financial reporting, learning the language for auditing, more scientific auditing or monitoring, and understanding what the monitors want or what the auditors want to check that you're doing the study correctly, which is really important, or doing your financial paperwork. Even those language issues can be really difficult, and and just involving everyone on the team. Many people, obviously do not speak English. Their expertise is in other areas, can be really complex.
Yeah, I was just gonna add, I think, so for one of the ways we've overcome some of those barriers in terms of like the regulatory translation of documents and things like that, we've outsourced that to a vendor who specializes in sort of scientific translations of documents, and even still, we've had to. Oftentimes, these vendors have a focus on just directly translating things, but to the point of what adding to the point of what Bethania was saying, there's not a direct translation when you have a specific set of terminology in a sector. So oftentimes if you're using the word patient or subject or participant, if it's translated into a different language, oftentimes it's not the same translation directly, and there's a different terminology that's used in a different language. As for collaborating internally with teams, I think working in a global health setting is a true testament to being multilingual or sort of making sure that you have staff on your team who can speak other languages. Oftentimes, I think it's undervalued as quote unquote a soft skill to be able to speak Spanish or Portuguese or whatever the case may be in that particular setting, but it really is super useful. So in my case, I am Brazilian and we work with a Brazil team. And so oftentimes it allows for a very useful or very helpful translation between our staff members who may not speak as much English from our Brazil team. And similarly for, I know that's the case for our other team members or other staff from different partnerships who speak Spanish and work with other Spanish speaking countries. Yeah.
Thank you so much, Kaige. I agree. I think we are probably out of time here, but appreciate all of the wonderful remarks from our panelists, and we continue sharing in the lessons learned across the network as we move forward and work on these important prevention studies in people living with HIV. So once again, thank you to everyone, and thank you for the audience participation and for listening. And we hope you enjoy the rest of the symposium. Thank you.
Thanks, everyone.
Thank you.
Thank you.
Gracias.
Thank you very much to Emma and to all the panelists on this session that just completed. And huge congratulations to you all for the work that you are doing. And thank you very much for sharing it. Not only the content, but also the format, having that, the way you presented all of that information and allowed each of the panelists to elaborate was a really great way to have a deep dive into the discussion. So thank you again to that whole panel. And as a reminder, that was the second of 3 of our scientific sessions that will be held throughout the course of our symposium. And so with that, I'm very excited to now welcome Dr. Rose Anorlu to give today's closing remarks. So as with Dr. Kazap, who gave our opening remarks earlier today, Dr. Anorlu has been a member of the Scientific Steering Committee for ASGCR for 2 years. She is the immediate past president of the African Organization for Research and Training in Cancer and is professor of obstetrics and gynecology at University of Lagos in Nigeria. So Dr. Anorlu, you are most welcome, and thank you very much for giving today's closing remarks.
I would like to thank all of you for joining this session. And I also like to thank Professor Eduardo for his comprehensive closing remarks on this section. Now, the world is a global village now, and we know that the cancer is also growing. I mean, it's getting common all over the world, and the LMICs are having a disproportionately high burden of this cancer. And collaboration between nations or between the LMICs and the high-income countries will help to close this gap between LMICs and HICs, that's high-income countries. And throughout this presentation, in the last 3 sessions, we heard a lot about these collaborations, the research that is going on to help to close reduce the cancer burden in the LMICs, and so as to close the disparity in cancer care. I would like to invite all of you to tomorrow's session. But before then, I think most of you would have learned a lot from the 3 sessions, and you are going back with new ideas, especially those in low and middle-income countries, to do research which will be beneficial what you have in your environment. There's nothing like a small research. Any research that has an impact is a good research. So I think we shouldn't even, get so worried about not doing, the high molecular research, genetic research, which is not available in our countries. But I know that through collaboration, we are going to get there one day. Collaboration between nations, partnership will one day get there. Slide 3, please. Yeah, okay. So tomorrow's section is Rachel Perlin award. Is basically, that's the main event there tomorrow at tomorrow's session. And I hope you all be there, and then you hear about the wonderful thing that young fellow in hemato-oncology did in global health. Did to help in global health. She did a wonderful job. You're going to hear about all that. And with that, as you on the 4, the program is there. The program for the 4 is there. And next slide. And for those of you who are not able to join us tomorrow, please complete this post-symposium survey. Click the link of the chat to fill the anonymous 10-minute survey to help us to evaluate this symposium and to improve it in the future. Thank you. Last slide, please. Thank you for joining us, and I will say goodbye.
U.S. Department of Health and Human Services, National Institutes of Health, National Cancer Institute, cancer.gov, 1-800-4-CANCER.